Good afternoon. Good morning. I think we'll start. It's lovely to see everybody here, and I think some people are still joining, but we'll make a start. We've got a very full agenda today. Welcome to Resourcing for Health in the COVID era, Maximizing Bang for Buck. This webinar is co-hosted by the Action for Global Health, the George Institute for Global Health, and the UK Working Group on Non-Communicable Diseases, with support from the NCD Alliance's Solidarity Fund on NCDs and COVID-19. My name is Alison Beattie. I'm a health and systems specialist working in health and development. I've been kicking around for about 30 years in a variety of countries, and perhaps most recently, before I became an independent consultant, I was with DFID, heading up the health program in London. Many thanks to everyone who's joining, and especially our speakers today. I'm going to introduce them one at a time. A bit of housekeeping before we start. You can post questions. Please use the Q&A function, and also comments as well. We're recording this webinar in order to have it available later, and we'll be doing a report in addition. There's a tweeting hashtag, which is hashtag resourcing for health. Please go ahead and use that at will. We have, as I say, a fantastic lineup, so we want to get cracking on. Now, the context for this webinar is perhaps important just to summarize. We've got this confluence of numerous factors coming together: a decline in development assistance for health since about 2015. It's a steady decline. An increasing economic development in a lot of countries, especially generated by a different way of calculating GNI, that's made a lot of countries find themselves in a situation where they're not as eligible for development assistance as they once were. COVID-19 is absorbing a lot of the funds that are available, and there are a number of unintended consequences coming out of the COVID pandemic. As we all know, economic pressures on countries, especially donor countries, as well as all countries across the world. And then there's, in addition, a risk to gains that have been made in the past, combined then with further constraints on really making sure that resources are available for the rising priorities, the increasing priorities around NCDs, mental health, and the effects of climate change. So this combination of pressures is really creating now huge resource constraints, and perhaps will be the mother of invention, creating a lot of necessity around improving resources better. Let's move to the next slide, please. I'd like to just set the scene then by reminding us all of the larger context in which health is unfolding in many countries, and that is with our handy universal health coverage cube. Really not to spend much time on this, but to remind us that what's important around health is making universal coverage, is making services available to the widest number of people possible, and doing that in a way that is that pays attention to equity, broadening the range of services available to the largest number of population, and doing it in a way that maximizes the use of funds. Rob Yates is going to talk us through some of the detail of that in just a minute. So raising funds, pooling resources, and spending funds is really the structure around which we want to talk about raising resources. And where are those resources coming from? They come from largely through domestic sources. External funding for health is really quite a small proportion, as we know. So direct taxes are the mainstay of funding for health in most countries, and that includes taxes on individuals and companies and what is earned. There are indirect taxes as well, and these tend to be raised in terms of on what is spent. So VAT or sales tax, excise tax, and others. And then there is non-tax revenue, which is revenue from national wealth, for example, from sovereign wealth funds and from state-owned companies and enterprises. And then lastly, of course, we do have resources that are externally sourced, including concessional loans from development banks that are an important source of income as well. The first part of this webinar then is going to really focus on raising funds for health. How are we going to raise, pool, and prioritize the way in which funds are made available for health? And then we'll move on in the next part of the webinar to talk about how to get better value out of the resources for health and more bang for buck. So without further ado, I'd like to introduce Rob Yates. Rob is a political health economist. He specializes in universal health coverage. He's currently the executive director of the Center for Universal Health at Chatham House, and he's an honorary associate professor at LSHTM, a consultant to the elders on their UHC group. Rob, I'm handing you the floor now for 10 minutes. Thank you very much. Over to you.
Thank you. Thank you very much indeed, Alison. And it's a pleasure to be with you all today. Greetings from the Virtual Centre for Universal Health at Chatham House, where we specialise in issues around the political economy of health and health reforms. And it doesn't get much more political than how you finance universal health coverage. I think, years ago that there were thoughts that this was sort of quite complicated, particularly in terms of where do you get the funding from? And we're going to be talking in the rest of the webinar about, where are the best allocations? Where do you get, best value for money out of what you raise? But where you get the money from to finance healthcare, I think is really quite clear now. And that is through public financing. If we could have the next slide, please. Because this was a photo taken at the high-level meeting in 2019 on universal health coverage, and this is Gro Harlem Brundtland, the former Director General, of course, of WHO and Norwegian Prime Minister, talking about universal health coverage and saying if there's one lesson the world has learned, is you can only reach UHC through public financing. About 30 years ago, there was a sort of a terrible period where right-wing governments and the likes of the World Bank were very much pushing private financing, trying to push the financing burden onto households. But that was a terrible mistake. And we now recognize, and as Alison's slide showed before, all those financing mechanisms were really some form of public financing one way or another, as I'll outline now. So next slide, please. I would say this is the consensus now on health financing. I mean, many of you, people of like Alison, my generation, have known this has been quite a lively debate over the last 20 or 30 years. But I think it's one that's very much resolved now, or resolving, recognizing that market-driven, privately financed systems where people are buying and selling health services and just consuming what they want and charging what they like will never, ever, ever lead you to universal health coverage. And you've only got to look at the US health system to sort of see that that's not where you don't want to go. And really what UHC is all around is about healthy, wealthy people paying for services for the sick and the poor. And left to their own devices on a voluntary basis or on a charitable basis, that will never happen at sufficient scale. So the state has to get involved. The government has to get involved to force healthy, wealthy people to cross-subsidize the sick and the poor. And of course, the state gets involved in those three functions that Alison mentioned, raising revenues. How do you do that fairly and equitably and efficiently? How do you then pool all those revenues so that you've got a lot of resources to spend? And then this vital aspect of where do you spend the money? Where do you purchase the services? I'm tending to deal with the money raising bit, and very much want to sort of suggest to the group, and quite happy to debate with members who might think otherwise, but the public financing is the key. And there the main mechanisms are general taxation financing, a lot of the mechanisms that Alison mentioned, but also compulsory social health insurance. So that's sort of linking people's salaries basically to how much they pay into the pool. But there are limitations with social health insurance, and particularly having a strong link between employment status and health service entitlements. And as populations age and you have a sort of a smaller working population, dependency ratios rise, you can see you can't just depend on health insurance contributions. So all systems depend very heavily on tax financing. So I think when we're sort of talking even about innovative financing mechanisms and where are we going to get the funding to help collectively as work out what's good and what's bad, we should be restricting really the debate to what public financing mechanisms are we looking to, and completely stop notions of charging healthcare user fees, private health insurance, voluntary community health insurance sounds good, but basically doesn't work, and we should sort of stop flogging that dead horse. So next slide, please. And I think this sort of illustrates, countries' journeys towards universal health coverage. So this is actually from Asia Pacific, but very similar graphs for Africa as well, and in fact everywhere across the world. That the countries towards the bottom right of the graph there, they tend to be wealthy countries. They've got high levels of public spending as a share of GDP, and that reduces the financing burden of households, enabling people to get healthcare, and most importantly, protecting them from these terrible out-of-pocket spending episodes that plunge families into poverty. And the countries at the top left there are those really starting their UHC journeys that need to make this transition. And moving down this curve is all about political leadership, putting big increases of public financing into your health system. What's interesting is that countries tend to do that quite suddenly, and that's often led by heads of state. So, we recognize some star performers, the likes of Thailand, that's performing very well. Everyone knows it's a great UHC success story. That was the big transition in 2001, when the Prime Minister decided to cover everyone, basically using tax financing. So the question is, how do we catalyze this? How do we encourage this process? Next, please. And I sort of want to sort of conclude really my little segment to suggest that rather than be thinking, oh my goodness, how on earth could you do that at the moment? Everyone's worried about fiscal space and public financing being under attack. Quite the converse. Now is the time to use the COVID crisis to catalyze big increases in public spending. And I think there are very good reasons why this may well happen. In fact, we're seeing it happen. So we mustn't be told that the money isn't there, because across the world, there's this massive crisis requiring immediate actions from heads of state and right across government. And where people are really pressurizing their governments is around issues of access to health services, particularly vaccines, of course, but also financial protection. They need to protect their incomes and their livelihoods. And this is universal. Everyone at all income levels wants this. People are desperate for particularly COVID-related services, of course, at the moment. But we're also seeing, I'm sure we'll discuss this, many NCD services being displaced, and people are really desperate for their cancer treatments and their screenings and all these other NCD services. And people want action quickly. Now, I would suggest that this is a massive opportunity for CSOs to be campaigning for equitable UHC reforms, including NCD services. It's vital that we don't hear it, well, okay, we might just have enough money to cover people against infectious diseases and pandemics, but NCDs are going to have to wait. No, quite the opposite. Now's the time to be pushing much harder and faster for the benefit package to be extended to NCDs. And I just want to give one or two country examples to wrap up now. So next slide, please, of where this has happened before. Famously in the United Kingdom, coming out of the Second World War, we were bankrupt. We were dependent on US aid, a post-conflict state, and we launched the NHS. And against all odds, managed to create this fantastic entity in a couple of years. And of course, we celebrate it to this day, as the photo on the right shows, from the Olympic Games in 2012. And it is the UK's most popular institution by a long, long way, coming out of a crisis. Next slide, please. And here's the Prime Minister of Thailand in 2001. After the Asian financial crisis, he came to power saying he was going to bring universal free healthcare to the masses. The World Bank basically said, no, you can't do that. There's no fiscal space. You mustn't do that. he ignored them. He introduced universal health coverage, put about 1% of GDP into the health system, scrapped all user fees, and the rural poor in Thailand still worship him for that. And you now have the World Bank congratulating Thailand on having ignored their advice. But, very interesting, that we need to make sure that the World Bank stays honest on this and doesn't start telling countries again that there isn't the money to do this. Next slide, please. And just a couple more. Fascinating. China, after the SARS epidemic in 2002, had realized that it was moving into a sort of a US-style health system, privately financed, and actually with WHO and DFID support, undertook a lot of research about how are they going to sort out their health financing system. And basically they decided to plow in something like $600 billion worth of tax financing to re-socialize the health financing system, coming out of a coronavirus related pandemic. So China did this about a decade ago, 18 years ago. Next one, please. South Africa, you've seen South Africa's right in the thick of these debates at the moment. President Ramaphosa, they've got a great plan to introduce a national health insurance scheme, and President Ramaphosa is specifically saying they're going to use the COVID response to accelerate the UHC reforms in South Africa. These are the countries CSOs, I think, should be focusing on and supporting, because if South Africa can do this, hopefully it will encourage others to do likewise. And I think my last example might be the United States. So next slide, please. Yeah, so the big one. Joe Biden just elected, desperately in need of a quick political win. Trump completely screwed up, of course, and largely got voted out of power because of the COVID crisis. And Joe Biden now, in a tweet in November, saying that come January, just been elected, of course, at this point, he's going to bring universal coverage to the United States. And I really think that all of civil society shouldn't ignore the US, and we should be engaging in these debates. Because if the US goes this way, then it will sort of stop this notion that somehow a privately financed system is a good idea. So I think that might the last one I said. Let's next one, please. No, just the role of civil society, and of course this is the purpose of the webinar. I think to campaign for this, to really sort of regard this as an opportunity. This is a photo taken from Bangladesh. Now is the time for civil society to be rallying round and fighting much harder for universal health coverage. And hopefully we'll find some political leaders in need of a quick political win, realizing this is the best way to salvage their political careers. Thank you.
Thank you very much, Rob. It's a great illustration of the old adage, don't let a good crisis go to waste. We'd like to move on now in this webinar to really focus now on how to get more value and bang for buck out of the money that is available. There are a lot of ways in which spending money more smartly is going to increase the bang for buck, pooling resources more efficiently, prioritizing with more transparency, improving service efficiency. You see here a list of different ways in which this can be achieved. We're now going to ask three different speakers to present small case studies that each individually explore one aspect of spending money smarter. By the way, let me interrupt to say there are some questions coming on to the Q&A. Please feel free to add your questions. Also, please feel free to up them. You thumbs up them somehow, and that pushes the question to the top and indicates that it's a question that lots of people would like to ask, and we'll get to work on answering some of those questions at the end of the speaker comments. I'd like to first then invite James Sale to give us some remarks related to the way in which mental health services can be improved and strengthened in a context of resource constraint. James is an advocacy and financing manager at United for Global Mental Health. He's previously in a part of Save the Children, global health and financing work on policy and advocacy, and also established Transparency International's health sector anti-corruption program. He has worked in vaccine surveillance, so well positioned now to give us some remarks more focused on mental health. So James, over to you now for 5 minutes. Thank you.
Thank you, Alison, and hello, everyone. So I'm here to present about mental health financing, and with only 5 minutes, this is going to be a whistle-stop tour, but I'm sure we can circulate slides out afterwards. What I'm going to run through is, I'm going to give you the current context and a bit of background on financing for mental health. We're going to look at the global overview, what's going on at sort of across the world, and then I'm going to focus in on a national example to finish with. Next slide, thank you. But the first thing to say is that I'm going to talk with you in figures that are so large that in many cases, the individual at the center of them is completely lost. So my first point to make is that not only is person-centered treatment required in mental health, so is person-centered thinking and advocacy for mental health financing. At United for Global Mental Health, we call this approach the return on the individual. Next slide, please. Now, the stats for mental health are stark. As an area of the health sector, it is so far behind physical health. But it should not be seen as a subsector of health, but one that is cross-cutting. And it needs to have relative parity with physical health, and that includes in financing. In fact, in WHO's founding documents, the right to health is the right to the highest attainable level of physical and mental health. But mental health is simply been left behind. Next slide, please. COVID-19 has brought mental health out of the shadows in global health, and the world is now fully aware of the fragility and the importance of mental health. And this step change in the international community has been seen over the past 7 days or so at the WHO Executive Board. Next slide, please. With mental health high on the agenda, and so far 45 member states and counting gave their support to the Director General's report on mental health preparedness, response, and I would say recovery from COVID-19. And I'd recommend anybody to go and read that report to get a good overview of what's happening and what governments are committing to. So, looking at global mental health, well, with less than 2% of health budgets globally being allocated to mental health, and that's less than 1% in low and middle income countries, and less than 1% of development assistance for health being allocated to mental health, the levels of financing in mental health across the world are incredibly low. And this is especially true when considering the health, economic and social and societal burdens that ill mental health presents. And some of these can be seen here. By 2030, the cost of mental health could rise to $6 trillion. But if adequate investments are made, then this could be overturned and we could see $200 billion gained in productivity, for example. Mental health, I should say, is the #1 reason for absence from work. Next slide. And the classic return on investment in mental health is simply a financial return of $4 to everyone invested. And in fact, this ratio has recently been updated to 1 to 5 and will continue to grow as more research and resources in mental health are given. But the return on investment goes far beyond dollars and cents, and to improve society's physical health outcomes and ultimately the person. And I said at the top of the presentation, we call this the return on individual. But without scaling up public finance for mental health, we will see an alarming rise to continuing the prevalence of common mental health conditions. But as we can see here, with an increase and improved public mental health financing, we can see a significant and almost immediate impact, not only reducing case prevalence of common mental health conditions, but really flattening the curve. Next slide, please. So I'm going to finish with an example of mental health investment from a West African country. We conducted this investment case, but it's not yet published. So I'm not going to tell you which country it is, but it helps me make 3 points. There's a lot of figures on here. Don't worry, I'm going to run you through them. So the first point is that the bar is currently so low in so many countries that we're not expecting governments to spend the required amounts overnight. The international recommendations for mental health is that in low and middle income countries, 5% of health budgets should be spent on mental health. and in high-income countries 10%. And if you remember at the beginning, I said the average is 2%, dropping to 1% in low and middle-income countries. The jump is significant to get there. So it has to be in a phased approach. And now in this example, the country's actual very good mental health policy was budgeted at an average of $5 million per year. But currently, literally a few thousand is being allocated, and even less is being actually spent. So the approach given is one that it gradually increases over a decade, and then leads to exceeding the current budgetary needs, going from, you'll see the top line, a few cents to per capita per year to 50 cents for the first few years, then building to $1 and $2 towards the end of the decade. So what does this mean for the mental health budget? I think if you click next slide, we'll be able to look at a different part of this. Yes, so initially the percentage is under the 5% recommendation as I just mentioned, but then it rises to 6% and then over 11%. Now this comes to the next point, is that this might be too much for the mental health budget, but the mental health is not the sole financial responsibility of the health sector. So if we go to the next highlight, we'll see that actually mental health is the responsibility of not just the health sector, but the education sector, social protection, penal systems, etc., and have all a responsibility in delivering modern mental health policies. Mental health is a cross-societal issue, and so cross-governmental approaches are needed. Here, even the highest mental health spend that is suggested is less than 1.8% of the predicted total government budget at the end of the decade. Next highlight, please. And so this leads me to my third and final point, and this is about the potential of return. So we talked a little bit about the sort of return on investment earlier on, but here, even with modest projections, we can see that by the end of the decade, there could be an accumulative return of nearly 170 million for this country if they invest just to the levels required to deliver mental health services to an adequate level within the country. And that is a huge return for countries in a time when we're entering very constricted economies. So we should not look at mental health finance as an expenditure, but really we should be looking at it as an opportunity for countries to generate more finance and improve their economies. So last slide. It just allows me to say that the current situation for mental health is really poor, and we can't get around that. However, mental health presents one of the greatest opportunities in investment within the health sector. Thank you, Alison.
Well, thank you very much, James. It's an excellent illustration of the value of actually finding the resource to invest upfront now, despite the larger context in which we're operating, specifically in order to get those returns in the future and to offset the development of deeper, larger health problems in the future. So it's a wonderful example of the case to investing now. Finding that resource is, of course, one of our challenges. And our next speaker is Jonathan Cushing. He's the head of Transparency International, the Global Health Program, and has been working for 15 years in health system strengthening in various countries across Africa and Asia. Jonathan's going to talk to us about the work of Transparency International around addressing corruption, mismanagement, waste, and this is a critical part of the story of getting more bang for buck. So Jonathan, over to you for your 5 minutes. Thank you.
Thanks, Alison. And yeah, I'd like to give you an example of one way in which we can improve resource utilization in the sector, and talk today about the impact of corruption and inefficiency on the health sector. Overall, it's estimated that public procurement is 1/3 of total government expenditure globally. This equates to about $13 trillion per year spent on procurements of various items. And estimates suggest that between 10 and 20% of this is lost annually due to corruption. It's incredibly difficult to estimate how much is being lost, because if you're good at corruption, you obviously don't get caught. You don't want to make it very obvious. But what we do know is that the effect of corruption and also inefficiencies in the system result in large losses. And often health systems, as with all other systems, are quite opaque, complex systems that mean it's very hard to detect what's going on in them. And that often when corruption is uncovered, it's often just the tip of the iceberg. Looking at the health system and the health value chain, there are opportunities for corruption and mismanagement to occur throughout it. And if you can see the diagram on the bottom of this slide, it's an attempt on one slide to kind of summarize the health value chain as such. So starting kind of throughout the process from the kind of, if you look at the pharmaceutical, drugs manufacturing industry, technologies industry, research and development, manufacturing, right through registration, marketing, what a country chooses to purchase, and then how it purchases it, how it distributes it, down to the kind of patient level and the service delivery, what the individual the doctor or nurse prescribing actually decides to prescribe, whether patients can access services that are meant to be free, or whether they have to pay for it. There are multiple opportunities for corruption within this system, with the net impact that the patient gets suboptimal care ultimately, and health outcomes are suboptimal. What I'd like to look at today is one specific challenge. So next slide, please. And also then discuss some of the responses to it. The challenge and the area I'm looking at is procurement, corruption in procurement. The threat, as everybody might have guessed, is COVID-19. We've seen corruption. Sadly, this has been a tale of two pandemics, really. COVID-19, the pandemic itself, but also over the last year, we've seen repeated incidences of corruption occurring in countries around the world, really, in the response to the pandemic. If you look on Twitter in the UK and follow the Good Law Project, amongst others, you'll have seen the kind of the multiple issues raised there, and the allegations of what's been termed in the UK the conchomocracy, opaque deals going on, direct procurement channels, and this is not unique to the UK by any means. On the flip side, what the pandemic has done is highlighted the impact really of poor procurement, poor planning, and in dealing with the pandemic. Everybody is really now aware of what happens if you have substandard PPE, personal protective equipment, what that means really for patient and health outcomes. One response to this, and this has been going on since prior to the pandemic, is to actually open up those contracting systems, to start letting people start getting greater access to show what's going on in procurement. This is open contracting, and effectively it's bringing that contracting information out into the open, saying that everybody can see it, everybody can see what's going on. This allows governments to see it, as well as CSOs and anybody interested in it. And in doing so, you can start using data, start flagging suspected corruption cases, but also look at how efficient the system is, begin to start trying to understand and unpick what procurements are taking place and what they're being used for, and how that then impacts ultimately on health outcomes. Got here, and sorry, this is only a 5-minute presentation, don't have time to go into it, but an example here of the top tenders in Uganda, where you can see very easily the number of tenders, and if this was a live demonstration, you click on, you can see the total volume of awards there, and drill down to start seeing who's procuring what, which government agencies are procuring what, who those tenders are going to. This makes it very easy then to start looking into further issues about beneficial ownership, start questioning, is this company who's been awarded all these tenders, perhaps a relative of somebody in power? What has actually been procured? Is this drug actually coming through the system? Let's say that ARTs are being procured, but there are none on the shelves in the local pharmacies. We know we've got an issue there, and start looking at some of those kind of system blockages. Next slide, please. And I think, as Alison said, or Rob said, this is also an opportunity now. We've seen COVID-19 is going to present us with ongoing challenges. We know there are some very hard decisions that are going to have to be made. as the amount of money shrinks going forward, and there will be tough choices going ahead. In response to that, what we would like to see is that across the system, there's greater fiscal transparency and accountability. Procurement is one part of a complex resource allocation process. And this slide shows it again here. The resource allocation, the decisions that ministries of health, devolved health administrations take on where to spend the money are not just on purchasing items, but also on where to deploy staff, perhaps who to train, what services should be provided. However, in a lot of countries, this is often quite a linear vertical process. Feedback mechanisms are not in place, or if they are in place, are suboptimal to get that information back to inform future planning, future resource allocation. And at the patient level, at the community level as well, those systems are often not in place to allow for greater feedback and input into what's actually wanted from health services at the local level. Communities don't always have access to the information to let them understand what is going on in the healthcare sector, and to feed in so that and to ensure that local healthcare providers are held accountable. We'd like to see more use of information, more understanding of it, and more transparency across the systems, opening up all of these points in the system so that resource allocation decisions are done in a transparent manner, but those decisions can then be tracked throughout. Information's available, allowing anybody who's interested, and that includes CSO, kind of patients' rights groups, health groups, to actually start understanding that information, using it, and to drive efficiency forward. Thank you.
Alison, I think you may be on mute.
I'm very sorry. I just had a bit of a wobble on my internet. So these things happen at the least convenient times. I hope you can hear me now. Thank you very much, Jonathan, for those remarks. I mean, it's incredibly important how that resources are channeled in exactly the way that we think they are going to be channeled. We certainly don't have scope to lose money through either mismanagement or through corruption. So very, very important part of the story. I'd now like to turn to Dr. Jane Hurst. She's a consultant obstetrician and clinical academic based at the University of Oxford and also working with the George Institute. Jane is leading a team in Oxford and India to develop a smart health app, which she's going to talk about. One of the critical elements of this work is around investing today in offsetting serious illness, but also anticipating and investing in the prevention of disease in the future, especially critical NCDs. So again, getting more value out of health investments, both now and in the future. So Jane, over to you. Thank you very much. 5 minutes.
Thanks, Alison, and thank you for the opportunity to speak here. I guess I come at this problem from a slightly different perspective than the previous speakers, in that I'm sort of more a frontline health worker. And one thing that I've noticed over my career in obstetrics is, fortunately, worldwide, things are improving for mothers and their babies. And since the Millennium Development Goals, we've had a lot of investment into maternal health around the world. The journey's not there yet, and there's still a lot of room to go. But the real question now is, can we leverage some of that wonderful investment and building of systems in maternal health to really help women and children's health for the rest of their lives? Next slide, Anna. Oh, thank you. So during pregnancy, the most common medical disorders that we see are two conditions, one called gestational diabetes mellitus, affecting up to 1 in 7 women around the world. And the second one is blood pressure disorders of pregnancy, which can affect up to 1 in 10 women. And that includes things you may have heard of, such as preeclampsia. And what we know is that women who develop these conditions are at greatly increased risk of developing type 2 diabetes after gestational diabetes. About up to 50% of them will have it within 5 years. And when we look at hypertensive disorders, around 1 in 3 of these women will go on to have chronic hypertension. And these two conditions are the leading risk factors in women for cardiovascular diseases, and really identifies a group of women at increased risk of premature morbidity or death from stroke, ischemic heart disease, chronic kidney disease, and other things. So the focus of the work that we're working on at the George Institute and Oxford is trying to break this link, trying to really, as I say, leverage what we learn in pregnancy to have savings for people's future lives. Next slide, Anna. So, as mentioned, what we're working on is a project called Smart Health Pregnancy, and it's really aiming to integrate non-communicable disease prevention into pregnancy care. And so the aim is, as you can see down in the bottom left corner here with the yellow box, is that we want to provide mothers screening, interventions, and regular follow-up after a high-risk pregnancy. So how are we doing that? Well, it really centers around utilizing the community health workforce at the front line. And we're working in India, but these cadres of health workers exist in most countries around the world. And it's hoped that we may be able to adapt it to other settings in the near future. So these community health workers identify women in their villages and their communities who are pregnant and register them on a tablet app. They're trained and given support to be able to perform simple measurements like blood pressure, blood glucose testing, testing for hemoglobin. They enter this data on an app which gives a clinical decision support assessment, i.e. low risk, medium risk, high risk, and some simple advice if it's things like diet or lifestyle that needs to change, or can refer them on to primary care if medications are needed. And the idea is that this starts in pregnancy, but then for the high risk women will continue thereafter. Next slide, Anna. Thank you. So where are we up to with this work? Well, just to give our case study of where we're going, the question that really remains to be answered is whether this approach can really help these high-risk women achieve target blood pressure and blood glucose in the years after birth. So to answer this important question, we're conducting a large cluster randomized trial in 2 states in India. We're going to be recruiting around 20,000 pregnant women and following them for up to 5 years. We've been talking with partners on the ground in India to plan scale up from the start. And I think anyone who works in global health will recognize this is essential if we're going to have buy-in from local partners, ownership by the local people, and really responding to what are the local priorities, needs, and capacity. And then alongside this, exploring sort of sustainable financing models for this. The problem with preventative health is the return on investment, if you like, is many, many years down the track, whilst the problem we have is right now. So how can we convince governments and health payers that this is a reasonable approach to take to build on the pregnancy investments that we've made? And this then leads into sort of addressing implementation and system challenges. So while scaling up to deliver this to 20,000 women is going to be a big effort for us, there are over 25 million babies born in India every year. So you can imagine scaling up to a national level intervention requires quite a high degree of coordination and planning. And finally, I'd like to touch on, well, if we can use this sort of platform as a springboard from maternity care into other aspects of onto diabetes and hypertension, could we use it for other neglected aspects of women's health? And specifically, mental health, which I think James, has highlighted to us as a huge problem worldwide, but particularly in women and particularly around the time of pregnancy, as well as cancer screening for things like cervical and breast cancer. Could this also be integrated in this sort of way? So that's my case study that I'm presenting, and looking forward to the discussion as we move on. Thank you.
Thank you very much, Jane. So that concludes our 3 case studies, and what we've really been able to explore through those case studies is the importance of investing in the right services, the importance of ensuring that we invest not only for today but for the future, and invest in prevention as well as treatment and cure, and that we ensure that all available resources for health are in fact reaching their target and being spent on what we intend for them to be spent on. We have to maximize the use of every dollar and be as creative as we can in terms of the way in which those resources are used. Now, the elephant in the room, of course, and not even an elephant, we've talked quite a lot about it all afternoon, and that is COVID-19 and the challenges that it is presenting. We have with us now as our final speaker, Javier Belloc, who is a representative of the Health Systems Connector of the ACT-A Accelerator, which is the global financing effort around COVID-19. Javier is going to talk us through what is the ACT-A, why is it so important, what resources are being made available, and where do those resources come from? You know, some of them are redirected, some of them are new, and will enable us to then have a discussion about how we're going to use those resources to really punch above our weight, as it were, and ensure that we're addressing COVID, but also addressing as much else as we can, making sure we don't let that crisis go to waste. So Javier, thank you very much for joining us. Over to you now for your comments and remarks for about 10 or 15 minutes. Thank you.
Thank you, Alison. Welcome, everyone. As Alison mentioned, I have been working not only Universal Health Coverage 2030 Steering Committee, but also more recently in the work stream that works on the COVID toolkits, accelerated tools regarding the health system. The next one, please. So I don't pretend in 10 or 15 minutes to introduce on a very complicated creature called ACTA, or the COVID Tools Accelerator. I hope you have access to the presentations, but you can also visit any global health institution webpage, for example, especially WHO, where you can find all the resources around ACTA, which explain the structure, etc. But it's basically a collaboration to accelerate the development, production, and unequitable access to COVID-19 test treatment and vaccines. It's now that we are in the vaccination startup season or process, equitable access, it's becoming an issue, or probably something that we might be concerned about the performance of ACTA in this regard, or COVAX, which is particularly the group who look into vaccines. But later on, another, let's say, a work stream was added into the equation, the fourth pillar, as we call, which is health systems. And in the second paragraph, you see all the global health institutions and private foundations who are behind the COVID accelerator. Next. So how it is organized, as I said, there are like work streams, so we changed the name like 4 times, but it's around diagnostic, treatment, vaccines, and health system strengthening, health system period. All the pillars are interlinked, and there are multiple meetings that cross-cutting issues across the diagnostic, treatment, vaccines, and health systems. The initial idea of health system was to probably glue or link all together diagnostic, treatment, and vaccines, but of course it became quite clear that health system by itself it's something that requires special attention. So there is cross-cutting work, and there is also some vertical and precise work, and for example, vaccines or diagnostic, it's like a perfect example where you need to articulate with health system, deliverable, accessibility, infrastructure, but also you have a vertical approach on developing diagnostic, treatment, or vaccines. The next one. So that's how the ecosystem looks like. So you see the main stakeholders, funders, and supporters of funders of the ACTA, not necessarily funder of the ACTA investment case that I will come in a minute. And then you see inside what are the main things what we work in. But what is important that this is we used to call a private-public partnership made by governments in the industries, and especially civil society, and all the UN agencies and global health institutions. We manage now to have civil society representation in each and every work stream, working group, across all of these areas, including vaccines. Next. So, as I said, meaningful involvement. For us, as a civil society representative in health system, we have a very complex system. We have around 100 civil society reps because we need to provide civil society representatives, for example, in a working group in COVAX, looking into in-country preparedness, for example. So it has been very challenged. We have a civil society facilitation council. We support people. And one thing I want to underline, which is something very many people in Europe, in particular in the United Kingdom, understand what long COVID is. For us, it's coming very clear that people living with long COVID should be part of the civil society engagement, as meaningful involvement of people living with HIV or hepatitis happens in the HIV or hepatitis response. Next one, please. Thank you. So there, for your use, there is what we call the investment case. Then there is a lot of information. I steal some of the nice pictures from here, but I want to leave you with these 4 links. You can basically go into the WHO page and put COVID, and you might probably find the sequence of the 4 documents. But I think it's an interesting journey, few pages, which is a miracle for WHO, to understand what ACTA is about and the role of each stakeholder. Next one. So it's important. I mean, the mantra is prevent, protect, treat, and test. No, and of course now in the news and in the discussions, the vaccines has becoming more relevant, thanks that there are much more development, and we are now facing the goods and the bad stories about accessing. What happened with the health system is that two things that came across very strongly is how we find enough resources for support the procurement of personal protection equipment. And as you hear from my colleague from Transparency International, it is a target for corruption, as other procurement in many countries, and oxygen. We have been trying to coordinate and link all the pillars and thinking on how the health system could respond to some of the issues of accessibility, and as Robert mentioned, the ability to pay and this catastrophic cost for families of getting multiple pre-conditions and then COVID on top of that. But what happened for us and the health system, that we were compelled to focus on PPE and oxygen. And you can imagine that it's not easy, not only to send the machines that produce oxygen to put it in a tube, also to get in the full infrastructure in some challenging operational environment. The next one, please. Next. Okay. So as you see, that is not a take us for a surprise. I remember, I think it was in December, Ryan, the emergency director of the WHO, saying, this is not only about a virus, this is about equity, this is about money, this is about access. That is what are killing people. And we all know that. We don't need WHO to remind that, but that's important. If you see access levels of those tools in lower income countries, it is an issue. Of course, in the media and in our countries, because the COVID do not discriminate about income necessarily when affect or spread, but the ability to respond, of course, is linked to the low income countries and your local investment on health and the support you can get from international financial support. Next. So rapidly closing, the ACTA accelerator urgent financing gap is 4.6 billion. I mean, how we evolve in each of the clusters or pillars, it was by developing investment case. You see there the investment case. You see there the capacity to scale and procurement, country delivery capacity, product development. That's a picture from November, if my memory serves me well. And we're learning on the vaccine dimension that some people did a bit of miscalculations about ability to produce, ability to procure and distribute. Next. Well, I will not stop there. I mean, as you can imagine, diagnostic, therapeutic, and vaccine is about basically test people with the best and accessible, cheap, and friendly diagnostic, good diagnostic tools. In terms of therapeutical, it's more focused on acute cases and the use of dexamethasone and other monoclonal antibodies and other promising treatments. And of course, vaccine, I don't need to tell that. Next. So the sharp focus on integrating country plans to address system bottlenecks and critical health system tools. So what we have been discussing in the health system connector is now moving into some countries. We are discussing now which those countries will be, but they will be rolling out some of the tools and some of the things at the country level, mainly probably in countries in Africa. And that's also posed us with a big challenge of provide civil society participation at country level in multiple countries. But of course, will include the vital supplies of PPE and oxygen. Next. Next. So I keep on time. Okay, so the funding gap for ACTA Accelerator is 38.1 billion. That's the money that needs to deliver on what the 4 pillars has been discussed. In the case of the health system, is 9.1 billion. You need to understand that there is a lot of assumptions when you develop an investment case on a new pandemic and after a year, and things are moving all as we speak, are so dynamic. That's the euphemism we use. Next one. But it's important to highlight, as all other speakers did today, the human cost in this case of COVID. It's not only about the people infected and the people who passed or has been killed by the virus. Is that the cost of the global economy, 28 trillion is estimated by 2025, sorry, and the 495 million full-time equivalent jobs will be lost. So I think that links in some way the other speakers' concerns about access and accessibility, equity, etc. So we should remind that it's not only about how much a vaccine doses cost. Next. And the unforeseen health and human costs is, for example, I take one example because I have been working on HIV/AIDS for 32 years, but worked in other diseases. But I take one concrete example. During the last year, there was a non-access in many countries to combine prevention interventions and commodities such condoms, loops, and pre-exposure prophylaxis. No access to timely HIV diagnosis and treatment went really down in many middle and lower income countries, and even upper or developed countries. Low retention in health system treatment interruptions, stockouts, increase on stigma and discrimination with HIV key populations and criminalizations. You know, many army people, uniformed people in the street securing lockdown. Key populations like a transgender woman might probably face different kinds of institutional violence, increase of gender-based violence, mental health, something that many people do not speak very often. And when we will read when we will see the real picture of the horrible legacy of COVID. Next. So my final thoughts. We do not have a resilient health system. When I started working in UHC many years ago, we navigated all the process until the high-level meeting, and we dream on resilient health system across all the spectrum of income levels. We learned with a huge acute pandemic that not even the more rich countries could ensure a resilient health system. For the right, for the reason we know, right? We do not, but it's also a caveat here. We do not take seriously the work on virus X or the potential new pandemic, where like Gates Foundation and many other, how you say, think tanks in the global north, in the global south, has been warning for decades about keep emergency stocks, training protocols, because we might face a flu-type pandemic or respiratory pandemic very soon. That was speech in the air. The COVID response has been politicized in so many countries, in so many regards, not only in the so-called north, also in the so-called south, and you know that. We continue to fail on communication on health and health crisis. One of the big gap in the response to COVID has been communication. We tend to create structures and tools from the north to the south. Some of the recipes we receive here living in the south come from different contexts and different health insurance and health systems. Don't wait 50 years to learn lessons, because we might probably face another pandemic in between, hopefully not. Accountability, transparency, and accessibility is something it's more rhetorical than a reality in the response to COVID. The resources are there and are here in the South too, in middle income countries where most of people with the diseases live, most of the people with COVID live, but there is an issue of improper allocation, corruption, and we still buying military equipment in Latin America instead of investment in health. And I think that is the last one. Yeah. Thank you very much, and I encourage you people to visit the publications in WHO and other organizations. Thank you, Alison.
Wonderful. Thank you very much, Javier. Very interesting comments and remarks, and we've had a number of questions coming up in the Q&A, and thank you people for those questions. Please do keep them coming. Javier, let's just stay with you for a minute. Unexpectedly, I know we were going to do things a little differently, but I'd like to just stay on your subject just briefly, and let's bring into play some of the questions that are coming up. You know, there's not enough money. You've highlighted the lack of funds, the huge need. How are we going to make decisions given that the resources may or may not be there? What are the processes that will be followed over and undertaken over the coming months in order to make critical decisions about how best to use resource availability? How are we going to know if those resources have in fact really punched above their weight and achieved as much or more than we ever anticipated? And a final question to tag on to that: what about the role of advocacy in that process? What can we expect from CSOs? What should CSOs especially be trying to do, aiming to do in the course of this year in order to accelerate and improve and strengthen resource allocation at this time, which is where things are very constrained? So if we could just have your thoughts on that, and then I'll turn to the other panelists. Thank you.
Sure, thank you, Alison. Well, let me start by thinking that 2 years ago, the Global Fund for Fight AIDS, TB, and Malaria replenished 16 billion for granting projects or funding national strategic plans for the 3 diseases in developing countries. Of course, this money comes with an agenda, especially transitioning out of middle-income countries, which has a process who has been started for a while. So much of the work we actually do in middle-income countries, this a spectrum, because I'm not a very fan on how World Bank estimates income without living in one of the more unequal regions of the world. But I think that we know what we advocate at the global level is that there is enough money for continue increasing the investment, not only in AIDS, TB, and malaria. We in UHC, we say that there is enough money to support lower income countries from global solidarity to response to diseases. As Robert very eloquently said, the money should never come from the pocket. This is catastrophic cost, and people will die and will be impoverished. So take away this out of the equation. So lower income countries will continue depending on whatever better structure we can develop on global solidarity. Middle income countries, which is probably my expertise, the money is in our budget. The money is there is fiscal space. We can create we could be creative around taxation in many of middle income countries. The problem is that there is not the political will. As I said, we're still buying weapons, or the allocation of the money is not follow the commitments they signed in New York around any issue, including universal health coverage or high-level meetings on TB, HIV, or hepatitis. So I think that civil society and advocates have a long way to go and on pushing middle-income countries to pay most of their health costs, because the money is there, and is not properly allocated. That is my response. So that's what we try, that our fellow colleagues working across the diseases, communicable and non-communicable diseases, prevention, comprehensive health, sexual and reproductive health and right, push their governments to invest in the right thing. My last point is, let's imagine I am Argentinian, or let's imagine Brazil in the future with another government, really putting all the money from domestic sources. Argentina, Mexico, or Brazil do not receive external funding for health. The problem is how we support civil society organizations that do watchdog, transparency, and advocacy work, where the money will come from advocates in Mexico who are tracking the investment and expenditure on health. That money needs to come from outside. The people are not happy to feed the dog that bark to you or bite your hand. So as a community of advocates, we really need to call the attention that if we continue to watch what happens in India, in South Africa, or in Brazil, and other middle-income countries, we need some support from abroad to continue to be independent and out of jail. Thank you.
Thank you very much. Continues to be very interesting. Let me, at this stage, just ask Joe Keating from the FCDO for a comment on the COVID Act A. Joe, would you like to make a remark?
Yeah, hi. Sorry, I'm trying to get my video on. Oh, there I am. So I really welcome this discussion. I know lots of people on the call, and I think we are in a difficult time, but I do think we need to stop kind of kidding ourselves that the resources are limited. I think in terms of what Javier said on ACTA, the health systems ACTA is a connector. It's not about mobilizing more resources. I think it's about using the resources that we have available, whether that's from a domestic or an external through the GHIs or through various programs more effectively. And I don't think we're thinking enough about really where the efficiencies are in terms of service delivery models that include a new era of delivering new pandemic response tools. COVID isn't going to be the only one. And we need to really think of the next level and really use this to scrub the way we are delivering services so that they are the most efficient to meet those that are most left behind, as Rob said right at the beginning. And I think that throughout the discussion, we need to be really careful that the domestic resource fiscal space is going to be limited too. So having an economic argument for one thing versus another actually is fine, but that's going to result in us changing how we talk to each other in terms of what is put forward to a government, in terms of consideration, in terms of what the public financing space gets what they are going to prioritize. And I don't know whether we're being honest enough with ourselves that we've really looked at collaboration and coordination in terms of really working towards the UHC agenda. And I would say that ACTA HSS, coming back to the original question, is a point in hand. The budget and what Javier's presented is for oxygen and PPE. It is not for the systems work that needs to actually happen to deliver just COVID. But it's not just COVID. I don't think of it as just delivering COVID. I think of it as delivering the diagnostics for the infectious diseases, improving information systems so that governments are able to have a much better picture in terms of where ultimately they are going to allocate their resources. So my question back to the people on the call is really, where are, one, the bottlenecks in terms of the integration and efficiency agenda, and two, where are the opportunities that we can take all of this forward? I think donors are probably as much to respond, we're as much a part of the problem, but we need to find solutions. And so let me leave it there, and really grateful for this webinar, and thanks.
Wonderful. Thank you very much, Joe. Rob, let me turn to you then. How should we go forward in a context in which we need to be honest with ourselves about the resource constraints? Prioritization is a major challenge, and we need to be sure that, that we're investing in systems in order to sustain and really strengthen the capacity to deliver health in the long term, taking advantage of this crisis. Have you got any comment on that, please?
Yes, certainly, and thanks very much for all the comments. I mean, clearly we've got the situation that it needs to be context specific. There are some countries that are performing extremely well in the crisis, and we're seeing the likes of Thailand, Sri Lanka, Vietnam doing very, very well. I think if you combine those countries, I'd be surprised if they've even reached 1,000 deaths between them so far. So you're having some countries performing very well indeed, and they are tending to adopt, a very primary healthcare focused, very efficient way of dealing with things. Lots of non-pharmaceutical measures that have worked very well. So there are plenty of really good examples of sort of countries that are performing well. I think in terms of countries that aren't performing so well, and to answer Joe's question about sort of the bottlenecks, so where are the big numbers of people who are not only really not being, effectively covered in the COVID crisis, but the long-standing problems of poor performance in UHC. And I think that one sort of looks around the world and recognizes, that's tending to be concentrated in sub-Saharan Africa and South Asia as well. And there are a number of very big countries that basically are not spending much money at all on their health systems, flatlining at about 1% of GDP. India, Pakistan, Bangladesh, Indonesia, Nigeria. These are big countries where, to be honest, aid isn't going to make that much difference. A number of them are middle-income countries now. And the big bottleneck there that has to be overcome, and this is like the elephant in the room, how do you get those countries to move from this flatlining 1%? I think the Indian government's going to announce the budget this week. I bet it barely changes. It hasn't changed the last decade. What is it going to take to get India to suddenly do what Thailand did and put about 1% of its GDP into its health system, focusing on primary healthcare services, paying frontline health workers, doing all the stuff we know that really works. I would say that is the big bottleneck, and also the opportunity that, you know, this crisis, I think, is just putting the spotlight on these underperforming systems. And I think there are even nuggets in these countries. If you take, for example, India, you have the situation that the Delhi state government, even in the run-up to this, was, you know, launched this program of Mahala clinics, urban-based community clinics, free medicines, free diagnostics, doing extremely well, and an excellent model for UHC in India and South Asia. And, you know, is this going to take off? I believe there are 9 Indian states copying this model now. It's very, very political, as any Indian the people on the call will know, that, you know, this is high politics. You know, these different models being pursued. But I think that the crisis does present an opportunity for truly catalytic and transformative health reforms in some of these massive countries. But our aid financing isn't really going to do that. It's a domestic issue, it's a political issue, but one that we can help along, I think, if we engage in the politics ourselves.
Perfect, ideal. Thank you very much. James, I'd like to turn to you now. There's been some chat about the mental health slides in your presentation. What's it going to take, James, then, for mental health to get onto the agenda? And is the evidence sufficient? Is it a question of political will? You've illustrated very carefully that the resources are not huge that are needed. So in your view, what is it going to take, to quote Rob's comments, in order to ensure that we get mental health onto this agenda now, in the context of COVID?
Thanks. So, you know, I think that we're already on that way. So possibly more than any other area of the health sector, mental health is in the public consciousness right now across the world. I think that's universal. And I think we need to be harnessing that and demonstrating to those decision makers that mental health is very important to populations, and therefore should be part of their planning, and they should be quite public about that. You know, Rob's always said that UHC is a vote winner. I would argue that mental health is heading that way, and I think it's really pushing for that political will. And maybe if you just allow me just to quickly answer Joe's questions with just a couple of points. I think in the long term, it's the bottleneck in terms of financing is the really boring budget financing stuff with finance ministries, and that is, you know, budget advocacy year to year. We've got to be looking at you know, medium-term expenditure frameworks, you know, over sort of a 3 to 5 year period, and making sure, you know, universal health coverage and things like mental health are in that, and then also that those are rooted ultimately in development plans for nations, which is sort of, you know, usually 5 to 10 years, and it's a process we've got to work to you know, really be embedding it in that. And then there's an immediate opportunity. I do think that finance institutions are going to be renegotiating debt with countries. And there's a chance that you know, things like buy downs of debt interest is going to happen. Now, the smart countries will take what they're offered in terms of, you know, the negotiations around debt, and knowing that most countries' debt crisis, or the coming debt crisis, is in foreign currency, that smart governments will take the sort of buy downs of debt in dollars, and then when they're asked to by finance institutions to spend that difference on social sectors, they'll spend it on local currency. And the health sector has a great opportunity to position itself where governments invest domestic resources in local currencies through things like training of community health workers, training of mental health workers, for example. And I think there's an opportunity for the health sector to position itself in terms of how governments spend money that they're asked to in local currencies following debt renegotiations with global financing institutions.
Thank you very much for those remarks. Jonathan, let me turn to you now, please. Thinking about all of these issues, what do you think are the critical barriers to getting better value out of the resources available, to reducing corruption? Why does corruption happen? It happens in every country, obviously. Some have systems in place that are more effective at identifying it. What are your comments and thoughts about this same question? Is the evidence there? Is the political will there? And what are the bottlenecks and barriers to improving the situation in this area?
Thanks. Can you hear me?
Yes.
Oh, great. Sorry, it's still showing as as muted. So I think we need to understand kind of in a lot of contexts why the corruption still happens. And also to look at some of the kind of underlying drivers of this. I mean, and Rob mentioned the kind of poor pay of health workers. And it's often very much embedded in the system. If you look at kind of a lot of countries, a lot of medical colleges in some countries, you have to pay bribes to get into the system. We've got to start at the kind of start unpicking some of this, and also build the political will around this to start addressing this. I mean, lots of governments come to power, parties campaign on kind of eliminating corruption, and then after 4 years, it's still basically the same. It's political will, but also the kind of social pressure for things to change. And I think this is the crisis, the current COVID crisis. We can turn this round and use this opportunity to start saying, look, this is unacceptable. This is happening. This is impacting people's lives. And I think in order to do that, we as CSOs need to start kind of making the case better and linking the corruption in the healthcare sector to the actual impacts that it has. So understanding what the impact of substandard medicines are and demonstrate it, substandard falsified medicines are, and then start demonstrating that and putting it in terms of kind of health outcomes. I think also this is the opportunity. I mean, there's kind of been a great deal of work going on in the health sector to kind of unpick these silos, get out of the kind of silo-based approaches or vertical approaches to malaria, HIV, etc., etc. CSOs need to start working more broadly as well. Those that kind of sit in the kind of fiscal governance, the fiscal accountability space, need to start working with those in the health space, start building up a common message and a common theme, and really get anti-corruption and also transparency onto the agenda. It's healthcare should be transparent. I mean, if you think kind of 30 years ago, before the internet, it was the kind of the preserve of the well-trained doctor who had all the answers. We've got much more information now about the system. We need to start using this and start demonstrating what the impact of kind of poorly planned, opaque health service delivery is. If we don't do that, we won't bring about the changes.
Thank you very much. Jane, I'd like to turn to you now. There's been a number of comments in the chat about combinations of services and especially around women's health, scaling up, linking cancer investigations and diabetes and so on. And also this idea of developing a package of services. What do you see as the pros and cons of fixing a package of services that are offered in the context of a health service? I can think of several reasons why we would do it, and a couple of risks about why we wouldn't necessarily want to do that in a primary health context. I wonder if you have some thoughts about that, especially from the perspective of, say, women's health or the health of women and children.
Yeah, thanks. I mean, complex question. I guess the first thing to note is what I've presented, where we're trying to integrate things into pregnancy, is not all women become pregnant, of course. And so, you risk excluding some women from this, package, if that's how it's going to be, the focus is going to be. So we'd have to think far beyond just focus, having one core package, which things are then tacked onto. It needs to be far broader than that. I think the other risk when, it's this, continual tension between sort of siloed programs versus more horizontal programs, in that, are we going to, all that good work that we've put into maternal health over the last, 15 years, are we going to dilute that effect? The evidence would tend to say, no, you won't. And there are examples, particularly with the mental health integration into pregnancy care, where both have run quite successfully side by side. But, you know, I think if we're going to start to expand it to a lot more things beyond the typical 6-week postnatal period, that evidence isn't there yet to say that it's going to provide an equitable solution for women. You know, I think it is essential that, obviously maternal and newborn health was one of the areas that was highlighted very early on in the pandemic, that, you know, when services suddenly were stopped and health workers weren't allowed to visit people's homes, that we would have a lot of, you know, suffering and deaths from non-COVID related things by that happening. So I know certainly in India, in the states I'm working in, and in other areas around the world, that was very quickly reinstated. But you know, to make sure that this essential, what should be in the essential package, which elements of NCD prevention and things should be in the essential package, mental health, these things, it clearly requires a lot more debate than I can give in this, you know, couple of minutes answer here. The final thing I just wanted to draw attention to when we talk about women's health is it's impossible to disentangle it from women's rights in society and the political will to invest in women's health. And so this is clearly something that, whilst affects all women around the globe, is very differently expressed in different communities around the globe. So I think, you know, whilst us health workers at the front line can advocate for things, we really do need the civil society organisations working beside us to try and, you know, bang at the doors of politicians to try and get the issues that women specifically face up the agenda. So that's, yeah.
Thank you very much. It's an excellent comment to end on, because it really raises the issue of the relationship between health and the adjacent sectors: nutrition, human rights, women's rights, education, water and sanitation, and so on, and the wraparound social protection systems that are needed. It's not just about health service delivery. We're coming to the end, but I want to give each of the speakers an opportunity, please, to make one final comment. And I'd like you to make some comments cater your comments towards thinking about what can CSOs do to advance this agenda, to sharpen the way in which resources are used, to advocate better for bang for buck, and to ensure that the resources coming into the sector and available to improve health are in fact used and directed in the right and the best possible way. So Rob, let me start with you. What's your final word on this?
Quite simply, to get political. You know, you know, we're going to have to fight for this. We mustn't roll over and just say, oh, we haven't got enough money, and then it all becomes a squabble between NCDs and infectious diseases. Now's the time for us to unite, particularly behind the UHC campaign, get political, and then we'll have a bigger cake to share out.
Thank you very much. James?
I would say that we're looking for efficiencies with mental health. You know, the integration of mental health into physical healthcare programs is hugely efficient, and we see that with issues like TB and people living with HIV, where they're much more likely to adhere to treatment if mental health services are available. But that also leads on to us having a broad approach. And as I said in the presentation I gave, it's not just the responsibility of the health sector to deliver health to a population. And in that case, we should be not just targeting, say, health ministries for increases of domestic resources, but including finance ministries, education ministries. It's got to be a cross-governmental approach to cross-societal problems.
Very good. Thank you very much. Jonathan?
I think people need to start questioning. This is, particularly as we move towards UHC, this is public money that's been spent here. Question where that money is going, question what the outcomes are, and that's civil society, but also individuals as well. That will build up a culture of accountability and drive the efficiency gains that we need to see.
Great. Jane?
Yes, echoing other comments there, and also what I said previously about, you know, really making sure that human rights, sexual reproductive health rights and things are integrated into this agenda and pushed forward at the same time as we try and decide how this finite bucket of money for health is going to be distributed.
Thank you very much. And Javier?
Yeah, I think that two short comments. One is, don't get trapped in structures and systems, civil society and community organizations, because that is self-serves and not probably deliver what our people need. Continue advocating, continue watchdogging, continue barking, because that is our added value, and some behaviors of our institutions and government did not change. Thank you.
Thank you very much. And to all the speakers then, get political, find efficiencies, question what you're reading, what you're seeing, investigate, get the information, link health to human rights. Don't get bogged down in structures and systems. Think big, advocate, and get noisy. I think that sums up what our wonderful speakers today have talked about, and I want to thank each and every one of them. Thank you also to the audience. There'll be a report from this. It's been recorded as well, and I do hope this becomes the beginning of a conversation and an ongoing dialogue amongst us all. It's been extremely fruitful. Thank you to our speakers, and good afternoon to everyone.
Afternoon.